Takayasu arteritis is an inflammatory disorder affecting aorta and its major branches. It is also known as aorta arteritis or pulseless disease. Arteritis leads to thickening of vessel wall, fibrosis, stenosis, and thrombus formation. Severe inflammation may weaken the arterial media and lead to aneurysm formation. Takayasu was an ophthalmologist who noted characteristic fundal arteriovenous anastomosis in a young female in 1905 and published it in Acta of the Ophthalmic Society of Japan in 1908. Onishi and Kagosha described similar cases associated with absent radial pulses in the same year. A study by Lupi Herrera and associates reported 107 cases over a 19-year period. In their series, females were predominantly involved in a ratio 8.5:1. Acute inflammatory phase with systemic and cardiovascular symptoms were noted in half of the cases. 65% had supra-aortic trunks and abdominal aortic involvement. Reduction in amplitude of peripheral pulses was noted in 96%, vascular bruit in 94%. Hypertension in 72% and renal artery stenosis in 62%. Heart failure was noted in 28% but rarely due to coronary arteritis. 48% had previous or current active tuberculosis. Another natural history study published in 1989 had 88 patients. The cumulative survival of Takayasu arteritis at 5 years was 91%. Of which event-free survival was 74.9%. 10-year survival of Takayasu arteritis was 84%, of which 64% was event-free survival. Of the 88 patients, 54 were female and 34 were male. The average age at onset of symptoms was 24 years, while that at diagnosis was 28.3 years. It may be noted that diagnosis is often delayed due to vague symptoms and subtle initial physical signs. Mean follow-up period was 83.6 months from onset of symptoms and 33.2 months from diagnosis. 10 patients died during follow-up and 22 patients had major non-fatal events. Those with single mild complication or no complication had a 5-year event-free survival of 97%. There were no deaths in that subgroup. Those with a single severe or multiple complications had a 5-year event-free survival of 59.7%. The mortality was 19.6% in Ishikawa groups 2B and 3, which were mainly due to cerebrovascular accidents and congestive heart failure. Severe hypertension, severe functional disability, and cardiac involvement were predictors of mortality or major non-fatal events. Ishikawa clinical classification of Takayasu arteritis had 3 groups with 2 subgroups for group 2. Group 1 had uncomplicated disease with or without pulmonary artery involvement. Group 2A had mild or moderate single complication. Group 2B had severe single complication. Group 3 had 2 or more complications. An angiographic classification was published in 1997 which had types 1 to 5 with 2 subtypes for type 2. This was formulated after a retrospective review of 102 Indian and 80 Japanese patients with Takayasu arteritis, comparing their clinical manifestations and angiographic findings. Type 1 branches of the aortic arch. Type 2A ascending aorta, aortic arch and branches of the aortic arch. Type 2B ascending aorta, aortic arch and its branches and thoracic descending aorta. Type 3 thoracic descending aorta, abdominal aorta and or renal arteries. Type 4 abdominal aorta and or renal arteries. Type 5 features of type 2B and 4 diffuse involvement. Involvement of coronary arteries is designated as C+ and that of pulmonary arteries as P+. In this study, significant difference was found between the two countries in the pattern of involvement and progression of Takayasu arteritis. In Indian patients, vasculitis generally occurred in abdominal aorta involving renal arteries and later spread to thoracic aorta in 1 or 2 decades. In Japanese patients, vasculitis generally occurred in ascending aorta arch or its branches and later extended into thoracic and abdominal aorta. Complicated lesions with prolonged inflammatory activity were noted in Japanese patients, while simple lesions were noted in Indian patients. A multicentric retrospective analysis of 49 patients with Takayasu arteritis refractory to steroids or disease-modifying drugs, mostly methotrexate and azathioprine, treated with biologics, tumor necrosis factor alpha antagonists, or tocilizumab, has been reported. Tocilizumab is a monoclonal antibody directed against interleukin 6. Overall response to biologics for Takayasu arteritis was 83% at 1 year, either partial or complete remission. The responders had lower initial C-reactive protein levels and lower requirement for steroids. Both C-reactive protein levels and steroid requirement decreased significantly at 12 months treatment with biologicals. The 3-year relapse-free survival was 90.9% with biologically targeted therapy, compared with 58.7% for disease-modifying therapy. There was no difference in efficacy between TNF-alpha antagonists and tocilizumab. Over a median follow-up period of 2 years, about 1/5 of them had adverse effects with biologically targeted therapy and 6.6% had discontinued treatment. The authors concluded that biologics for Takayasu arteritis had high efficacy and an acceptable safety profile. Here are the first set of journal references. These are the second set of references.